Atrial septal defect is the most common lesion in congenital heart disease. It's often diagnosed because of the lack of symptoms and physical signs. Agnès Pasquet will highlight how to use echocardiography to make the diagnosis, to establish the location and the relevance of the defect on hemodynamics.
I will present you the case of a young man. The physical examination shows a second sound at the pulmonary location delayed, and this guy complained on dyspnea of exertion. So as usual, I will start the examination by the parasternal long axis view. So this parasternal long axis view is quite not common, and you see already that you have a very large right ventricle here, and you can have a look here at this quite particular motion of the septum. If I put a M mode in the same location just to see, you can see this very strange motion, this very paradoxal motion, and this is the sign that you have a right ventricular overload. But we have to find the reason for that. So I will suggest first that we slightly tilt the probe from this position to be in modified parasternal long axis view. And if I show you that with the color Doppler, you can see that you have here the tricuspid valve. Normally you have here the interatrial septum, but you can already see some very strange flow here going through the interatrial septum, and you will suspect that there is an ESD at this level. To confirm my diagnosis, I will first go to the parasternal short axis and I will turn the probe to be in parasternal short axis. So now we are in parasternal short axis. This is the left ventricle, right atrium, tricuspid valve, left atrium, and you can see that there is some defect here. So this is the case of an atrial septal defect, deep ostium secundum, and I will show you later the difference between an ostium secundum and an ostium primum. What is important at this level is to put some color Doppler, and I will put it into exactly the same probe position. So I just turn the color Doppler on and look at the flow. It's important to look to direction. You see that it's mainly a red flow, that will say that the flow goes from the left atrium to the right atrium. In the opposite, if you have severe pulmonary hypertension or Eisenmenger syndrome, you will have the flow just in the opposite direction, and it will be mainly blue. So we can also assess the atrial septal defect in other position. And now I will move to the apical 4-chamber view. We are now at apical 4-chamber view, and I show you here this image. And you can see that you have a huge right atrium, dilated right ventricle, and that you have some defect here at this level. But be careful when you use this view, because it's just in the alignment of the ultrasound beam, and sometimes you can have some dropout defect. For this reason, I will suggest you to use this view, but it's slightly tilt your probe to have quite a modified 4-chamber view. And with this modified 4-chamber view, and you see here I have put side by side the black and white or 2D image and the color Doppler image, you will be sure that you are a defect, because now you are no more aligned with your ultrasound beam. And you can put the color and see very well this defect. By the way, you can also have a look here on the pulmonary vein, and look that this pulmonary vein is well arriving in the left atrium. But I just would like to go back 1 second to the regular 4-chamber view, so I does not move my probe, just to show you the difference between the ostium secundum and the ostium primum. As you see here, the ostium secundum is located just in the middle of the atrial septum. If you will have, and I will stop the image. If you have an atrial septal defect ostium primum, it will be just located at this level, at the level of the tricuspid and the mitral valve, and frequently you have to check both valves because you will have abnormality of the valve like a mitral cleft, and you have of course mitral regurgitation and tricuspid regurgitation. Then you have to assess. The next view that you can't use to see or to confirm the presence of the atrial septal defect is the subxiphoid view. And I will just show you the position so you know the regular position of the subxiphoid to see a four-chamber view. The second point that you have is to quantify the severity of the shunt that you have through your atrium. And for that, you have to make the measurement of the blood flow through the aortic valve and through the pulmonary valve. So let's start doing that, and I will start that just by going back to the parasternal short axis view, and at this view I can freeze and take the measurement here of my left ventricular outflow tract. This is the first measurement what I need to make a shunt report measurement. The second view that I need is to turn my probe to be in short axis view, and I will move at the level of the pulmonary valve, and here I'm still able to make some measurement of the right ventricular outflow tract. After, in the same position, I will put my pulse wave Doppler inside the right ventricular outflow tract and make some measurements. So I will take here with my cursor the VTI. I will also make the measurement of the distance between two QRS complex to have the heart rate, and after that I will move back to the apical four-chamber view. So I move to the apical four-chamber view, and I will take the measurement of the flow. So we have now the flow to the aortic valve, and I will say exactly the same. So I can have one idea of the shunt report. In this case, the shunt report was at 3. You know that frequently when you have a shunt report above 1.5, it's considered as significant, or when you have enlargement of the right ventricle, it's considered as a significant shunt. One other question that you may ask is what are the repercussions of the atrial septal defect, and for that it may be useful to go to the apical four-chamber where I'm still present, and to make the measurement of the flow through the tricuspid valve. So I'm in four-chamber view, I put my color Doppler on, and I will look at the tricuspid regurgitation, and I will put my continuous Doppler just inside to make the gradient and to have an idea of the pulmonary pressure. So it's just what I did here. So you have the measurement of the pulmonary pressure, and you can see that an estimation it's around 36 millimeter of mercury for the pulmonary pressure. So it's not very elevated in this circumstance. So I will be back of the assessment and also have a look on the right atrium. So this is a special mode where I use it just to show you the right atrium and the right ventricle, and of course you know that it's quite dilated. So this is quite important. One other point that you may have to consider is if you want to go for percutaneous closure. So it's important to make the measurement, and of course you will have precise measurement if you go for transesophageal or for 3D echo, and this is mandatory if you envisage to have a percutaneous procedure, but you can't already have a good idea of if it's feasible or not when you go to the four-chamber view, and I will freeze my screen here. So going back, I try to go slowly. What you have to do, you see that the diameter it's quite different through the cardiac cycle. What you have to do is to make the measurement of the greatest diameter here. And here I will say that it's close to 3.5 centimeter. It's really borderline, and I can consider that it's too huge for a percutaneous closure. So I think that we have assessed the atrial septal defect. So we saw the confirmation of the diagnosis, use multiple view, be very careful when you use the 4-chamber view because this problem of the dropout. It's important to assess the severity of the shunt. It's also important to look at the repercussion, right atrial dilatation, right ventricular dilatation, and also if you envisage to make a percutaneous closure, you can already have an assessment if it's possible or not.
So the important messages of this examination is that we have to use multiple views, that of course echocardiography is the first-line examination to assess the morphology of atrial septal defect, to quantify the shunt, which is very important for a prognostic value, and finally that we have also to look at the associated lesions at the level of the valves.